Testing 1, 2, 3. Testing 3, 2, 1. Testing 1, 2, 3. Testing 3, 2, 1. Test 1 2 3. Test 3 2 1.
Okay.
So the stream is live. Okay, test 1, test 2, test 3.
I can hear Derek. Yeah, well, I started the stream. We're just testing it to see.
Okay, hang on, wait. Test 1, test 2, test 3.
Hey Jeffrey, are you using headphones?
Hey, hang on one sec. William, go shut off the phone. Go mute the stream.
Okay. All right, Derek's about to go mute it.
Yeah. Okay, I'm sorry, David. What was your question?
Mute the stream.
If you're using a different set of headphones or something, because I can barely hear you today.
So, no, can you hear me okay right now? Stream's live. Okay, test 1, test 2, test 3. Test one, test two, test three. Okay. Test one, test two, test three. One, test two, test three.
Planning Committee on March the 4th. Glad you're all able to make it. I'm informed of no citizens wishing to address the board. So if I could get a motion to approve the minutes from the January 14th meeting, we'll get going.
Zim moves to approve.
Have a motion from Mr. Zimmerman
Amanda, second.
and Amanda second. Any questions? All in favor say aye.
Aye.
All opposed, same sign. That carries. All righty, Mr. Lane, consider approval of a $3.5 million of our $10 million budget for plant infrastructure repairs.
Yes, sir. So this, first off, good afternoon, everyone. It's great to see everyone again. So this is tranche number 2 of the $10 million infrastructure project. This is for the structural repairs to the roof deck of the plant. This includes the concrete deck, waterproofing, asphalt, temporary electrical, structural, consultant, and safety measures. And that is to bring us up to current structural sound condition.
So Adam, are you still on budget, and do you think you're going to have enough within this infrastructure budget to complete all the repairs you envisioned?
Yes, sir. So there's still $4 million left over, which is for the generators, because that is the big unknown remaining. We're still investigating the downstream wiring diagrams of those and tracing that. But we are on budget for the chiller project, which was previously approved. In fact, the chiller is due to deliver, I think, May 17th. We're already looking at working drawings for the installation of that chiller. And then this project, we do have the bid back for the structural component. I can report that vendor is 35% hub participation, so that makes me very happy. And we're just moving forward as fast as we possibly can.
Great. Any questions of Adam, members of the committee?
Nope.
Okay, then we would entertain a motion to consider this item.
This is Dorothy. Move approval of the infrastructure improvement.
Dorothy has a motion,
Second, DT.
and DT has a second. Any further discussion? All in favor say aye.
Aye.
All
Hey,
opposed,
Steve.
same sign. Oh, did I miss somebody? I'm sorry. Okay, I was just making sure. I thought I may have stepped over somebody there. All right, Adam, let's move on to item 3C. Consider approval of Meadows Mental Health Policy Institute as the consultant for the behavioral health program.
Yes, sir. So I'd like the planning committee to look at this contract and the contract with Broadus as essentially one grouping, but two separate contracts. This is for the mental health component of the bond program. Broadus did propose someone else. We have a standing relationship that Zelia can certainly speak to with Meadows. They're helping us with our anti-ligature projects, which is going exceptionally well. This group presents the best value for us on the programming side. And this is in terms of doing data, demographics, sizing, the actual architectural programming, meaning the space functional programming. We'll go out to bid for an architecture firm to do that. But this is for that component of sizing, right sizing the new behavioral health emergency center and hospital. And it is for $735,000.
Mr. Chair, if I could, before we have discussion on this item, I have made this known to the board, but I want to reiterate it. I have spoken to Daphne about this. Adam is aware and Zelia is aware. I serve on the board for the Meadows Mental Health Institute. I'm also on the executive committee. I've been on that board for 6 years. And I was asked to serve on that board by a gentleman by the name of Tom Luce. And I've been an officer in the organization. I was chair of their finance committee. I believe in what the organization is doing. I think they do some incredible work, but I've not had any part in this. And anything that is a potential conflict of interest, we will always report those, and I report those on my standards and paperwork of conflicts of interest as well. But I wanted to publicly announce that so that you all are not only aware but reminded of it, and that I did not influence this, nor would I ever.
Thank you, Mr. Early. Adam, one question that on my version, at least, and it may be an old version, none of the boxes are checked relative to the diversity procurement policy. As I understand it, this does meet that, but is that something to come later, or why aren't one of those boxes checked?
That's a good question. I don't know why that version is here, but this firm does not meet the hub participation. They went through that, but collectively, the Broadest Meadows group together is a 69% hub participation.
Okay, all right.
So we're well above our number. In fact, we are far exceeding what we have on virtually everything for the past several years within engineering, planning, design, construction. So this is going very well.
Okay. Any questions of the board?
I had a question. This is 735 unbudgeted in the bond package, and you stated that Broadus had somebody else in mind. I know we have a good relationship with it. So why is this unbudgeted if they had a proposal within somebody in mind to do this already?
Both the Broadus and Meadows contract are unbudgeted this year.
Mm-hmm.
And so I think, and Robert, you may want to address this, or Zelia one. I think to some extent, the past history we have had, Amanda, with Meadows, and has really been clear even since we began the RFP. And I think, and I was on that RFP committee, I think there's always been an understanding that there was a preference here that we partner with Meadows for this aspect of it.
Okay.
And I think the fact is the unbudgeted piece of it is just simply that it is ultimately intended, and Sharon, you correct me if I'm wrong, it's ultimately intended to be a reimbursed item for bond proceeds. Is that right?
Sorry about that. I had to mute. Yeah, so part of the overall 1.2 billion of projects, that is included in that. I think the unbudgeted reference is really just for this fiscal year. We are working through some of those estimates that we've just recently gotten. We didn't have any of that when we approved the fiscal year 21 budget. And Steve and I are going to be bringing a presentation back to Finance Committee to talk a little bit about some of those unbudgeted items that you guys have approved for several different reasons this year.
And to that, Trent, and to that, Amanda, we were very upfront with the teams that interviewed of our past relationship with Meadows. But Meadows also, and again, I don't want to jade it, but they're a national leader in sort of not only mental health care delivery. So we spoke pretty candidly to the groups about that. What I think Trent and I were surprised about is one of the groups that presented to us in the early stages of this used Meadows as part of their plan. And all of them could have, but I think they had the belief that if one group used them in their presentation, the other ones couldn't. We were a little surprised. We thought everybody would probably use the Meadows element to it. So I think that we were very upfront with people about the Meadows capability in this.
Yeah, I'm not concerned with the credentialing of Meadows. I've used them several times for other projects. They're a fantastic organization. It was just the funding with them, the budget of what was proposed by the project manager of why this was not included in that. But thank you for the clarification.
Does that answer your question, Amanda?
Yeah.
Okay.
I would just also like to add that we have an excellent working relationship with the Meadows Institute, and they, being within the state of Texas, but also national, have an opportunity to really take what we plan and what we do to the next level, and also potentially look at new funding revenues within the state and federal levels as well. So that's always an opportunity.
And to tack on to that, they've been nothing but responsive to us on the anti-ligature and already working on this from a thought content process. They've just been ahead of the game all the way.
Any other questions or observations from the committee? Okay, then we entertain a motion on this item.
Move for approval.
A motion by DT. Who'd the second come from?
Zim.
Sorry, Zim, thank you very much. DT motion, Zim second. Any question or discussion? All in favor say aye.
Aye.
Opposed, same sign. That motion carries. Thank you, Adam.
Mr.
And
Chairman,
next item is item 3D, which I know is part and parcel of what you just talked about. Do you need to elaborate on that one a bit more?
Steve.
Just a bit. So,
Trent.
this is the broadest levis
Adam,
portion.
can you hear Mr. Zimmerman? He's trying to interject.
I'm sorry, I didn't hear you.
Trent, with what's going on in the world right now, and the amount of mental health issues that we're going to be facing in the future, do we have any time frame as to when we're going to get this facility up and running?
I'll defer to Mr. Early and Mr. Lane on that question. I am not sure that there is a time frame scheduled yet for this. In terms of the building services, I think are a different question.
I'll
Can't answer.
I'll address that first, Adam, and then you can address the specifics of it. Zim, one of the things, ask for a time frame. There's not a direct time frame, and Zelia's smiling because she thought that time frame should have been 3 years ago, and so do we. I think our challenge is one of the key components that we want to do that creates, and Adam, you correct me if I'm wrong, but it's a bit of a domino effect, because our major priority is to get the emergency psychiatric services off the 10th floor. When you move that off the 10th floor, it begins to put things in motion. And the things in motion have to go as to where you move that 10th floor. And what we thought about is we would move that in a close proximity on the first level of where Trinity Springs is currently located. So that's not an excuse, Zim, at all, because there is a huge priority for this. It's just a whole lot more mechanisms got to come into place. It's a little more cumbersome. Adam, I'll let you address it, but to your answers, Zim, there's not a set schedule. There should be, and I think the Commissioners Court want that, and we want that, and we have to definitely push forward with that. Adam, you can give the specifics.
Sure. So I answer in two parts. On the excuse me, on the front end, in the functional space programming, the PEC, the Psychiatric Emergency Center, is the very first component that we are addressing, and that is in the schedule on page 42 of 53 in this section, and it's roughly 3 months of that. Once that's complete, then we can begin the process of going out for RFP, et cetera, and looking at funding on Sharon's side and how we're going to do this. But that gets addressed up front in this proposal, along with medical homes and the parking garage, which is a trigger project for all the other domino projects. More specifically, what is happening with this contract? The proposal came in at 9 months and $3.9 million worth of work. We have sat down with Broadus and we've had 20-ish meetings. I haven't counted. Those included strategic planning, also Sharon and finance, with Price Waterhouse and Guidehouse. And we've come to a scope that is significantly larger up front. And the reason we did that was, of course, healthcare has changed significantly. And as Trent and I have spoken, the Blue Ribbon Committee had a number of recommendations, but a lot of them were kind of guidelines on where we need to go. The master plan wasn't an exact master plan. It calls for buildings, but they're not very specific. This actually outlines all of that and gets it to a point that we can start functional space programming of each of those buildings, master planning across not just the campus, but also out in the community. And what this contemplates is tying in the current strategic plan that Lauren Poe is doing, and they're marching along simultaneously. So by doing that, we front-loaded a significant portion of the work. Additionally, what this does, this sets up the iterative process that we have talked about in the past, in that we need to be very thoughtful about our investment. We're not going to go and take $800 million in debt and try and build everything all at once. It wouldn't be prudent as an organization. And what this does is it sets up an iterative process of programming, read data examination, volume examination, before we initiate each and every project. So we'll have a baseline to go by through this $7.99 million. And then each time we initiate a project, we will supplement this agreement with Broadus for program management over those individual projects as they come online, as we go out to start to build them. Again, that will verify everything we're doing through 6 years, 7 years, 10 years, however long we decide to stretch out this program based on needs. And so if you have perused this by chance, you'll see there is a phasing plan for that first year. It's on page 43, I think, or 42. And it goes through those tranches of buildings that we're looking at. So the behavioral health emergency center is first, the medical homes, the garage, then the behavioral health hospital, then looking at what we're doing with the first hospital tower, and of course the central plant to support all of that, which will support the other components, et cetera, as we march down the line on these. It's a much more thoughtful approach, but it gives us the basis to make that thoughtful approach throughout the bond program through its life.
So I'll supplement slightly what Adam is saying. If you guys haven't had a chance to look at that Exhibit C in your backup, it does begin to sort of graph out and at least set initial timelines and priorities for the bond program. So if you haven't had a chance to look at that, I would encourage you to do so. And we're obviously going to be looking at that a great deal on the committee as it moves forward, but it is there and I hope you get a chance to look at it.
Trent, may I make a comment if I
Yes, sir.
In my book, pages 42 to 53, I couldn't read.
Okay.
They're blurred and they're small.
Okay. We need to get those. Anybody else have that same problem?
Yes.
You did, Jen?
Yes, I do.
Yeah, it's hard to read, but made it work.
Okay. Mine is small, but I can't actually read it. So I'm sure these are PDFs that were dropped into the package. So Adam, if you'll just make sure that we send a separate email to the board that shows, that has this on there as an attachment that you guys have been able to blow up and make large enough to read.
I'm making a note right now.
Isn't that what we saw, though, quite a bit ago in presentation?
No, not to this extent. This is the result of all the meetings that have been put together with Broadus to try to establish that overall scope and priority and schedule. Chuck, I don't think we've seen this before, have we, Adam?
Okay.
You have not. Again, keep in mind this is functional space programming and master planning and strategic planning with all the volume projections as well as for the buildings themselves. So this is very different than a schedule for building buildings. We're not there yet. We have to get through this process, but this sets us up for long-term success on this program.
Okay, great.
Hey, Adam, I have a question.
Yes, ma'am.
On page 27 with the assumptions on it, in the items of services not included, it states detailed engineering code and systems analysis for needed for design. So in this portion of the implementation phase, is this going to set us up to help with the architects to move forward? Because if they're leaving out the engineering and the coding and the systems analysis, then
right. So what we pulled out, because the board was so kind to provide for funding for the enterprise-wide risk management assessment, which is also on this agenda, and that is going swimmingly well. We will have all that data for them. But again, that's our existing facilities, nothing about the new facilities. So once the programming is done and we bring in architecture firms, of course, they will have their engineering consultants for all the new buildings that we're doing.
Okay, so this is just for laying groundwork and beginning portions, correct?
That's right. And so you'll see that it has master planning for mechanical, electrical, and plumbing. That is for the new cogen plant, and then how we will feed all these new buildings off that central plant. It also has components in there for geotechnical testing, traffic studies, so that we can start sizing garages and all these components, so that when we start marching into the building phase, we will have this data ready. It will not hold us up.
Okay.
Amanda, think of this phase as the big boxes.
The big bucket.
And then you get smaller boxes and smaller boxes until you get the final detail.
Yeah, that's a good point, Roger. I think one thing we want to do is sort of get in the habit of, in terms of setting our expectations for this project. Broadus is program managing, so we are keeping this at a very, very high level. There will be multitudes of documents that follow this related to specific contracts and scopes relative to these overall programmatic elements. So it's good to bring this up now because this is a pattern you all will see many, many times whenever we start going through the project.
And though I don't like to give David credit, but I have to give him credit. He had significant input on this from the IT side. But, generally I like to blame David for things because he throws me under the bus. So, but he did a great job here. So.
David Mendenhall?
That's correct.
Okay, just clarifying.
It's okay, Steve. It's okay. I get one a year. That's fine.
Mr. Chair,
earlier, David.
Tim, what might be helpful for you is next week when we have our strategic planning dialogue with you as a board. I believe that's next Friday. I think you're going to see a little more clarity as to how the strategic plan overall dovetails quite nicely into some of the things that we're doing with facility planning and where the bond goes. I think you may not have the specific on, April 15th, this starts or that starts, but to the point that you and Amanda as new board members raised when you first came on the board about where are we going, where's the plan? Dorothy and DT have said this for years. I think y'all are going to be pleased with the input that you all can provide where we're going. And I think that strategic plan will help all of us with y'all's input and direction as to where we go. And I think that will dovetail well into, let's start talking specific dates. I hope that helps them.
Well, the reason that I brought this, two reasons I brought this up. Number one, there's a lot of interest in this, not just by elected officials and whatnot, but other people. And the other question I keep getting asked is, when are we going to start doing something on the bond program? We've been a number of years since we had that election, and understand the reasons why we put it on the back burner, but I think now we need to go at it with a sense of urgency.
I totally agree. And to speak to the subject of timeframes, it's going to be challenging when your CEO says the meeting's next week when it's not until the following week. So I think that even got called into question. I think when we starting the bond package is really curious if I can't even get my week straight. So the meeting that you're going to have on strategic planning is actually going to be on the 19th. And I think that will be helpful.
We're not grading you on calendar challenge.
Okay,
I am.
because I just failed it.
I am.
All right, Mr. Petty, that's
all right. Level. Any other questions for Adam relative to the Broadus agreement? If not, then we need a separate motion to consider item 3D.
I move approval.
Montgomery, thank you.
Dorothy, second.
And Dorothy, second. Any question or discussion? All in favor say aye.
Aye.
Opposed, same sign. That motion carries. Thank you all very much. Okay, Adam, bring us up to speed on the MRI master plan project.
Okay, so this is for approval of the design firm Primera. They're a 100% minority architectural firm. This was within the 21 capital budget. It's for consolidating all three MRIs into one suite. We had 13 firms respond, and this firm was the best value for JPS.
Heard the discussion from Mr. Lane. Any questions or observations by the board? All right, will you entertain a motion?
This is Dorothy.
First motion from DT and Dorothy. Did I hear you second?
Yes. Mm-hmm.
Thank you all very much. Is there any question or discussion on the motion? All in favor say aye.
Aye.
All opposed, same sign. That motion carries. And we will go to item 4 now, our update for our IRMA, our Enterprise Risk Management Assessment, easy for me to say, project update, Adam.
So yes, sir. So we are starting to get the data back in content form now. The firms that were approved have spent a great deal of time going over our buildings. The data is significant. The dollar values are also significant, which is what we expected. The returns are impressive, what we're getting, in that how we can comb through the data and present the data. Our hope is that at the next planning committee meeting that we can run the planning committee through some of the software components that we have of this, showing how we can cycle through these buildings and look at the data from a priority matrix of year or priority of spend, or whether it's emergent or not. And we can do it across clinics, individual buildings, central campus site. It's pretty spectacular what's coming out of this. And it's everything we hope for. It's what you've been asking for a long time. And right now I'm looking through the pilot project, which is Jessica, and it's impressive what's coming out. I promise you, you will be pleased. It's pretty significant, and it paints a very clear picture of our assets.
Yeah, this has been a long time coming. I know many of you have been around as long as me and have heard multiple times us talk about the need for true capital project programming and scheduling, including, asset depreciation and when and how these assets need to be replaced and maintained. So Adam's been working very hard on this project, and this really becomes the gateway, I think, to opening up a whole new world for us in terms of the way we look at our assets and our maintenance schedule. So Adam, I appreciate all the work that's gone into this. I think it's going to pay big dividends for us.
Mr. Petty, I'd like to give a special call out to Lou Mattingly. He has been the project manager over this and overseen every aspect of it with a team of folks, and he's been phenomenal at what he's done. And again, the data we are getting will be impressive for everyone. It sets a true foundation for the organization.
Thank you, Adam, and a great shout out to Lou. I don't see Lou on the call today, but please pass along our thanks for him, because I know he has been burning the midnight oil to make this happen.
The team has been working exceptionally hard lately with what's occurred.
Any questions on the IRMA program to Adam? Okay, this does not require a motion or action. It was simply an update item. So, hello, Angie. How are you?
Doing well, thank you.
Bring us up to speed on our routine capital construction projects that's in your packet.
Yes, sir.
So, welcome, Angie.
Thanks. Good to see everybody, even virtually. The routine capital project I wanted to report on today is our 601 West Terrell. Y'all will remember that as our old cancer center, just a couple of blocks from the hospital. I did give you a visual on this one. I remember months ago in the last planning committee where I presented routine capital, y'all asked for a visual. So your second page of that shows the actual building. Like I said, it's just a couple of blocks down off of Hemphill. It relocates our services, behavioral health services, from 1617 Hemphill, which is an old building that we can't wait to demolish. We've had lots of volunteers to swing that sledgehammer. But Postdale Group, y'all approved them to move. I'm sorry, but y'all approved them to move forward. They are started. We are actively working over there. We anticipate completion of construction in June. Then we'll have to commission the building, get the FF&E installed, and I know no one's going to be happier than Zelia and her team to get this move accomplished. That's all I have to report today.
Awesome. Thank you, Angie. Any other questions for Angie?
When do you think to finish it, Angie?
We anticipate that's going to be June, June 2021.
Great.
Yeah, we're excited.
Good news. Good news. Okay, this is a project report also. We don't have to vote on this. I'm not aware of any executive session items, Mr. Early, or are there any?
There are no items that we have for executive session.
Okay, great. Any other comments?
That is correct, right, Adam?
That is correct.
Okay, you just looked up strange at me when I said that. I thought that was the case, and you had that
No,
look.
sir.
I thought, maybe I just made a mistake.
No, not at all. Just wanted to give a shout out to my team for everything that occurred during the storm.
Yeah, and Adam, I was going to ask you that question. I mean, we haven't gone into detail about what JPS went through relative to the Snowmageddon, but to the extent that you'd like to take any time here and shout out any of your team members or that whole team relative to what they had to go through and put up with, this would be a great time to do that.
Well, I would like to say something. So, like much of Fort Worth, JPS was not spared with respect to the plumbing, HVAC, water infiltration issues, as well as a myriad of other issues. I had the great fortune to work with the entire facility management team, whether it was housekeeping, laundry services, engineering, food service, the planning, design, and construction, the environment of care team, which were spectacular, and to witness them in action was truly miraculous. The things that they were able to turn around could not be done, but they were done. They were here from Saturday afternoon through the following Friday, 24/7. They were on triaging and mitigating issues as they arose all throughout the night. Frankly, the word dedication doesn't seem to cover what they were doing. They put JPS and the patients above all else, including their families in some cases. Unequivocally, this team, they're some of the finest human beings I've ever had the pleasure to know. And frankly, it's an honor to be their teammate. And I will say it's not just they make me a better leader, but they make me want to be a better leader and do everything I can for them. And it was truly humbling to watch them in action. It was awe-inspiring. They did things that could not be done. I just can't stress that enough.
Yeah, I echo that. I know everybody on the board. You know, that team was not only in our prayers, but forefront for days as we all battled that storm. It's amazing to me that I, as a board member, and probably many of you, we never even got a single complaint from families or from patients or from anyone at JPS, and that is an amazing thing when you consider the severity of what our organization and what our patients went through. So, Robert, to you and everyone on the team, Adam, your team especially, but this was a sacrificial effort on the part of JPS employees, and please don't think it went unnoticed by us at the board level, because it was a Herculean effort, and we appreciate it.
To Adam's point, we had Adam and his team did an incredible job. We had cots set up. Many people spent 3 and 4 nights at JPS. We had people in the laundry. We had people in the cafeteria. The food trucks could not get into the docks because of the ice. So we had a train of team members hauling things out of the major trucks and brought the food in literally by hand. And I think when you think about the 3 rules, Trent, they couldn't have been more in place during that time period, because people truly did own it. Everybody had a smile on their face, believe it or not. We had our team up on top of roofs at the temperature was -5, but the wind chill factor obviously much more on that, because a lot of our HV and systems for heating and cooling are on the tops of the buildings here. And then working and trying to find the gas leaks, and Atmos Energy actually did a very good job for us as well, quickly coming in and finding the gas leak, which is a major problem. So we could speak hours upon the incredible team at JPS, but the neat thing it was our doctors, it was our nurses, it was our executive team, it was rank and file, it was everybody in this organization pitched in, and it just makes you grateful to work at JPS. I reached out to Chuck Weber because I know what he and Dorothy went through, and numerous times they worked at JPS and saw challenges like this. But I called Chuck the day we gave out 950 vaccines, and I just thanked him for allowing me to work here, because that's the kind of place it was. It just made you feel great. So I don't want to give an oration about it, but it lifted all of us up to be able to work with people like that.
I will say, Angie said something this morning that was great. It was the greatest team building exercise that we could have ever had, spending 7 nights together in a row. And we went through it together, but we came out of it together. And that's what was really impressive about all of it.
Well,
The team is much stronger now.
I think the other thing to point out is, Robert, you mentioned people working in laundry and in the cafeteria and whatever. Those weren't their normal jobs. Those were completely foreign positions to just about everybody. That speaks a true testament to a great team.
Robert? Yeah, they were a great team. They did ask me after my 2 days of working in the laundry not to come back. So I do think I set the laundry back quite a bit. I think all of the sheets that I folded had to be refolded again, but they tolerated me and they were kind.
It's true. Quality control won't allow Robert back in.
Now, Robert should have been assigned to the cafeteria.
Yeah.
But Robert, aren't we going to see a short video on the 11th?
We are. The team put a video together that's going to be powerful, and we're going to show that to you at the board meeting and just give you a snippet of what took place at JPS.
Excellent. Thank you.
Great. Robert, thank you. Adam, Andy, thank you all. Any more comments or questions from the board? Okay, then we will stand adjourned. Where's Roger? Roger got through on time, buddy. All right.
Hi, this is Chuck Weber calling to order the virtual meeting of the Quality Committee on 3 p.m. Thursday, the 4th March 2021. And are there any citizens that wish to address the committee? Sean, anything that you know of?
No, sir.
Okay. Then we have the next number 3 is consider matters requiring committee action. The first is approval of the minutes from February 4th, 2021, and I'd entertain a motion to approve in a second.
Zim moves to approve.
BT second.
Discussion. All in favor, please say aye. Those opposed say no. Motion passes. The second one I have is approval of Tarrant County Hospital District policies and or plans. The first one is NPSG 100 patient identification policy. Dina. I see Dina hiding there.
I'm here. Good afternoon, everyone. Thank you. Thanks to the board for allowing me to present these 2 policies for approval. The first one is our National Patient Safety Goal 100 patient identification policy. This is a Joint Commission regulatory requirement. There's no changes to the policy, just some grammar changes and some descriptive verbiage added to the procedure that you should have in front of you. Just a reminder for the board, our 2 patient identifiers include legal first and last name, date of birth, medical record number, and a picture from our EMR. I'm asking the board for approval for National Patient Safety Goal 100 patient identification policy.
Any conversation from anybody? Then I'd entertain a motion to approve in a second.
Move approval. This is Dorothy.
Second.
Discussion? Hearing none, all in favor, please say aye.
Aye.
Those opposed say no. Motion passes. The next one I have is the NR 100 nurse staffing plan. Dina?
Oh, thanks, Dr. Weber. NR 100 nurse staffing plan is also an expectation from our Texas Board of Nursing and also our Joint Commission regulatory requirement. It's a policy that supports the need to have a staffing committee that is chaired and led by the CNO to review staffing requirements to make sure we have the staffing dedicated to take care of our patients in our hospital. I'm asking for board approval of NR 100. There were no changes to this policy, just updates of the references. Thank you.
I would make one comment.
Sure.
And that is that there's a requirement by the nurse staffing committee to submit to the Board of Managers at least semi-annually a report on staffing and patient care. And I'm just going to ask Sean or Suzanne to add that to the board calendar so we don't forget it.
Okay.
And other than that, I'd entertain a motion and a second to approve it.
This is Dorothy. Go ahead, whoever.
Go ahead.
That was DT.
He
I'll second
made the
it.
motion, Dorothy second. Any discussion? All in favor, please say aye.
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 Those opposed say no. Motion passes.
Dr. Weber, Rob,
Yes.
would you like that presentation to the Quality Committee or to the full board?
From the nurse staffing,
Yeah.
I think for the quality committee.
All right, we'll see to it. Thank you, sir.
Okay. Next one I have is, Dina, before you go.
Sure.
Congratulations on all the stuff that your nurses and whatnot have been doing during this COVID business. I know there's been a lot of burnout, and from my perspective, they've done a heck of a job.
Thank you. From my perspective
Pass that
also.
on.
Sure will. I appreciate it. Thank you.
You betcha. Next one I have is AA 2500 Research and Scholarly Activity. Dr. Elliott.
Thank you, Dr. Weber. Can you hear me okay? Good to see you. So good afternoon. We're seeking approval of AA 2500 policy on research and scholarly activities. This has actually been an existing policy that we had to update with regards to our current practices in research and scholarship to ensure that we have all of that documented and ready to go. And we were very thankful also to Daphne and her legal team with helping us, making sure this was ready to go. So we're seeking approval of AA 2500 research and scholarly activities in line with our current practices.
Anybody have any comments, questions for Tricia? Hearing none, then how about a motion to approve?
This is Zim approval of AA 2500.
Okay.
Second, Dorothy.
You have that, Suzanne? Okay. Any other further discussion? If not, all in favor, please say aye.
Aye.
Those opposed say no. Motion passes. Next one I have, Tricia, is there's 3 policies that you want to archive: AA 2200, AA 2400, and AA 2401.
Yes, Dr. Weber, we'd like to seek approval for archival of those 3 policies you mentioned, as they are also, the details of those policies are now entailed in our AA 2500 that was just approved. And so we have all of that information that's needed in terms of approval and conducting of research, along with research and scholarly activities and our IRB, and all the information is around federal and state compliance already in AA 2500.
All righty. Any questions, comments for Tricia? Hearing none, I'd entertain a motion and a second.
Motion to approve.
It's DT.
Sim second.
Jim second. Discussion. All in favor, please say aye.
Aye.
Those opposed say no. All 3 passed. Tricia, thank you very much.
Thanks, Dr. Weber. Thanks, everyone.
The next I have is consider performance improvement reports updates not requiring committee action. The first is PSI 90 and Quality Scoreboard, Rob Stevenson. I see you.
I'm here. Hello, everyone. Thank you for allowing me to present our most recent update to the board, to the Quality Committee of the board. Next slide, please. This is our AIP quality goal for 2021, PSI 90. January was a very tough month for us in this measure, as well as for our hospital in general, where we hit a maximum of over 200 COVID-19 patients in the hospital at one point during that month. A very, very profound surge in activity. That definitely had some spillover into a lot of our different quality measures. So we, in fact, in January had our worst single month with PSI 90 since we started putting real focus on this measure in the first quarter of fiscal year 2019. So that's quite a period of time. Anyway, this was driven by events across the board, probably most profoundly by a second postoperative sepsis for the year, as well as some pressure ulcers. Pressure ulcers have been a very significant problem, as you recall, from the previous spike in COVID that we saw back in July. We had a spike in pressure ulcers at that time for these very sick patients, and we saw a repeat of that with this profound spike in January. We put some real action around pressure ulcer prevention, mitigation. We sort of restored a lot of the good work that we had been doing, so that's back in process. And we are also blessed at JPS to have a new chief medical officer who happens to be one of the world experts in frailty, and we're beginning to really look at frailty as a way of really prehabbing patients for surgery. So our identification of frailty, prehabbing them for surgery, and also perhaps for those who can't be adequately prehabbed, even doing a better job of patient selection for surgery. So these are coming attractions, but we absolutely have our eyes on this, and we are going to be working very hard to make sure we don't see another month like this one. Next slide, please. So you can see we had 3 pretty good months to start the year, and then we've had this this major outlying month that has put us still slightly a bit better than what's expected at 0.98 is our overall score, but we're not near at this point, we're not very close to the threshold level for our goal for this year, which is 0.9. Next slide, please. So you can see we had some pressure ulcers. We had we've had some perioperative hemorrhages and hematomas. A lot of this is related to plastic surgery cases where you really have to be very, very sure that there's no hematoma at all. So they take them back very readily, even for the smallest hematoma, to make sure that things heal together correctly. So that's a bit reflective of a change in practice here, where we have a much more active plastic surgery program. But we have our eye on that, and you can see those 2 post-op sepsises are really the big drivers for our results this year. And we're hoping that a better focus on identifying and mitigating or improving frailty can have a real impact on that
Rob,
issue.
I have a question for you.
Yes.
The 3 post-operative hemorrhaging cases that you mentioned, did that require a return to the operating room?
Yeah, that's the definition. That's the definition. So if you take a patient back to the operating room for any reason, for a hemorrhage or hematoma, you know, that counts. And so if that's a 30 mil hematoma underneath some sort of flap, you know, rotational flap or free flap, that's significant.
Yep.
You know, for that you wouldn't take back a colon operation for sure. It's but you know, different operations have, as you know, different thresholds for when they would need to go back to surgery. But that's definitional for that particular measure.
Got it. Gotcha.
Yeah. So next slide, please. And then looking at our infection numbers, probably the big story for this year is CLABSI. We continue to do fairly well with colon SSI. So we're at 1.47 for the year, which is actually slightly, you know, right about the same as we were last year. Hysterectomy, we're doing quite well. Our hip and knee, we're doing quite well. The big issue for this year has been central line associated bloodstream infection. This is a multifactorial thing. The previous time we saw a surge in this, it was really exclusively in the COVID population. It's now much more multifactorial, and we have an active work group being led by Elizabeth Smith and Dr. James Bossert, who's one of our Master Black Belt Performance Excellence consultants, along with, you know, tremendous collaboration from both physicians, the critical care area, nursing, and others, to as well as infection prevention, to bring this into line. CAUTI, the catheter-associated urinary tract infection, is also higher than it was last year, and you know, again, that same work group is going to be looking at trying to drive that in a much better direction. We are doing about the same with Clostridium difficile infection, and MRSA is continuing to do very well this year. I think there is some additional room for improvement in C. diff, and so we're going to be putting some additional efforts around making sure that these tests are ordered correctly for the right patients, and that we're really identifying, you know, the most important infections and not non-infections. And the other thing is there's a new effort around antimicrobial stewardship here as well. We've got some new energy in that program, which again should help improve the Clostridium difficile infection issue. Next slide, please.
Before you go, can you go back to that, the star rating on the top left corner? Is there a current number than the Q1 2019?
Yeah, actually, that's a great point. Thank you for bringing that up, DT. Yeah, we actually just got a promotion in that. We've gone from 2 stars to 3 stars.
That's a big improvement.
Yep. So that's positive movement for sure. That's actually a really nice move in the right direction, and it's particularly associated with some improved performance in CAUTI and CLABSI, and the beginnings of some being able to take advantage of the good work in PSI 90 that we've been making. So I would certainly expect that to continue to improve. We're also have some, you know, probably we'll have some good news for the leapfrog safety grade for the spring once that's made official. So.
Congratulations. Thanks.
Thank you. Appreciate it, DT. Thanks for bringing that up.
Thank you, DT. Does anybody else have any comments or questions for Rob at all? Don't hear any, Rob. So how about next is patient experience, Laura Burnside.
Hello, Dr. Weber. Good afternoon, everyone. It's nice to see you all today. I wanted to take just a minute and thank you for the approval that you gave for us changing vendors for our patient experience surveys. That was completed toward the beginning of December. And I do have to give a huge shout out to our patient experience team and our IT team and Prescaney, who worked diligently to be able to get the survey up and running in the month of December. They worked all through the holidays and got the survey up and running so that we could begin surveying our patients as of January 1. And we were very successful in doing that. And so huge shout out to all of those who were involved in this transition. So far, we have about 6,500 surveys that have been returned since January 1st. And what's more interesting to me is that there have been almost 12,000 comments that have been provided. And what's really nice about that is that the data gives us a data point and stamp in time, but the comments really begin to tell the story from the patient's perspective of the things that we can work on. We found out a little earlier this week that we have been asked to be the 5th hospital in the country for Prescaney, for their clients that they work with, to utilize a tool called Narrative DX. And that tool is some artificial intelligence that will analyze these comments. Rather than us having to go through them manually, we can actually run this artificial intelligence, analyze the comments, and it will sort them so that we can really plan our action steps in a very detailed, specific fashion. The nicest and neatest part about this is that we can actually pick up to 10 different themes, if you will. So we can run the comments and sort them by zip code. We can sort them by age, by race, by religious preference, by language, etc., which will really allow us to be able to partner even more effectively with our diversity, equity, and inclusion team on what types of things do we need to teach and train in order to continue to build a culturally competent workforce that can take care of our patients.
Great.
The other really terrific piece of information with this is that because our employee engagement survey was also through Prescaney, our safety survey is also through Prescaney, and our patient experience survey is through them, they can actually overlay those surveys by department and by area, and we can do some analyzing of different areas on those 3 elements. So how satisfied and what is the employee experience like in an area, how safe do they feel when they're on site, and then how do our patients perceive their care as well. So there's some very exciting things on the forefront as far as patient experience and our new survey tool goes.
Good.
So once again, thank you. Yes.
No, this is DT. Going forward, each area, like the ED department and the hospital and the primary care and the MIPS and all that stuff, will have to do their own survey. Is there a plan in the future for us to consolidate so that we can have a more consolidated survey, patient satisfaction, all that stuff? Because when you use different vendor, it may see the same thing, but it's not consistent all over the place.
So we actually do, I think if I'm understanding your question correctly, the inpatient survey that we use is the HCAP survey that we've always used. That's the CMS tool. On the outpatient side, we actually have a tool that we utilize that allows us to have returns really kind of next day. And so it's a much more real-time survey that we utilize, and that is distributed electronically. So there's an email that goes out, text message that goes out that links them to that email so they can actually respond to that survey very quickly. And then we get that feedback back right away so that we can begin to action plan on it.
Oh, I see.
Yes. Does that answer your question, DT?
No, I'm more worried about down the road by 2022. You know, CMS have different requirements for that you have to submit to APP and all that stuff. And also, you know, there's inpatient, there's outpatient, there's primary care under some value-based contract, and then you have the ED and all that stuff. If everybody's using different methodology, it would be fine, but it's very hard for the whole health system to set the same standard, because each survey company may use different formula behind the scene.
Well, when CMS does require any additional public reporting, which we anticipate the OAS caps, which is the OR, is what's slated to be next. ED caps was on the horizon there for a while. That's been kind of taken off the table at this point. But any of the cap surveys that come through CMS, regardless of who submits those, there is criteria that has to be done in order to be an effective CMS survey. So regardless of who that vendor is that we work with, the mode has to be the same and the survey has to be the same, and there's a certain number that we need to get back. It's all very, very clear and specific. And we watch that all the time. So whatever's coming up, we keep that front and center for us.
Okay. Because they have to be credentialed for the APP and all that stuff also as well. Okay.
That is correct. That is correct. And Press Ganey is certified to do CMS surveys.
Right. I'm not worried about Press Ganey. I'm more worried about a different contractor that we use.
Got it.
Thank you.
Okay, my pleasure. You can go to the next slide if you would, please.
Laura, before you move from that and follow up to DT's question, how many different companies are you using? Because I thought Press Ganey was the one that you were using for the bulk of your surveys.
It is the only company that we're using for our surveys. Yes, we just do different surveys based on areas, based on national benchmarking.
Okay, all right. Well, I
yes,
thought it was
but Press Ganey is our patient experience survey vendor regardless of area.
Okay, all right, thanks.
Yes.
All righty. Okay,
so currently on the inpatient side, we are achieving 3 of our dimensions or domains in above the 75th percentile. And so as we're able to continue to drill down into this information, what I will be doing going forward is bringing back information based on the big rock projects that we have in place in order to move the needle on the inpatient or outpatient side. We have several active work groups right now working on a variety of different projects. And so each time I come back, I'll share information on what that committee or what that work group is doing, and you'll get a feel for what is all involved in moving the domains in each of these areas. Next slide, please. On the outpatient side, we're achieving just above threshold. We're at 62.7 on our questions. And so we'll continue we're making some really strong movement on both of these areas. And so I think over the course of the next month or 2, we should start to see a lot of the interventions that we have in place making some active changes here. And then the last slide are just all of the other areas that we are surveying that are, not part of our AIP or organizational goals per se, but certainly important for us. And these are all the areas that we're currently working on and have interventions in as well. So you can see 4 out of the 7 we are achieving goal.
Yeah, Laurel, I'll be intrigued to see what the telemedicine surveys bring.
Mm-hmm. Yep. Well, we're starting to see some tremendous movement on the outpatient side, so I think that's all part of it. And big kudos to all of our physicians and APPs who are conducting telehealth visits and who did so even during the middle of the snowstorm. I've heard tremendous stories about how they did that even without power, and were able to continue to do all of the patient visits that they needed to. So hats off and major, major congratulations to them.
Laura,
and then the last,
on that the slide that's up there now, what does the BH stand for?
Behavioral health.
Got it.
And then the last slide are just a couple of the things that we have going on. As I mentioned, there are multiple work groups working on multiple things. Our Care Transitions Committee has been really making some tremendous adjustments. If you recall where we started this year, we were at the 13th percentile, and our second quarter data shows us at the 75th percentile at this point in time. So we're really, it's not a year-to-date number, but that's where we are in second quarter. So I think kudos to that team for the work that's happening, and that's a multidisciplinary team all across the hospital working to make that happen. And then we also have our mastery program, our 5th cohort, which is in full swing, and we are creating a couple of new series of learning modules for the mastery program. One of them on ethics will launch very quickly. It is completed. And then we have 2 that are in the launch stage. One is for the Access Resource Center, and one is for community health. And so we've been actively working with all of our leadership team to make sure that we get that information out as quickly as we can, so that we can continue to move the needle on all of these things that are so, so important. And unless there are any other questions, that's all I have for today.
Anybody else have any comments, questions for Laura?
No, just what's ARC again, Lara?
The Access Resource Center.
Okay, got it. Thank you.
Yep.
Laura, thank you.
My pleasure.
Okay, COVID-19 update, Rob Stevenson.
So, you know, these COVID-19 updates are always fascinating to put together, because the pandemic and and what we're facing on any given day or week is so dynamic that what we put in for the board book is very frequently ancient history by the time it comes to actually present it to you 6 days later. So here we are with another slightly out of date COVID-19 update, but I will update the information as we go through. So this slide is relatively current. This is the pattern of the disease here over the last since the pandemic began. We of course had this huge surge in January following the holidays. It really started, you know, in November and just kept going up and up and up, and now it's come down very precipitously. Next slide, please. And you can see the deaths have also dropped, although they lag, because the time between contracting COVID and dying is a period oftentimes of several weeks. But you can see that you know, that is also now beginning to drop off. Next slide, please. And this is us at JPS. We've actually now dropped down to 47 total COVID patients in the hospital, and most remarkably, down to only 4 patients in the COVID ICU. So that is a tremendous drop that has really occurred very precipitously. You can go to the next slide. I think it's the ICU number. Yeah, and you can see, you know, when I made this now just a week ago, or not even a week ago, we were at about 15 patients in the ICU, and we've already dropped to 4. So we haven't been that low since late November, as you can see. And so now we are in the process actually of closing our COVID-specific ICU so we can do some needed maintenance work in there. But a really dramatic change in the pandemic over the last several weeks. Next slide, please. And so here, just to give you a little extra data, this has been the breakout of the patients at JPS. So the largest group here has been Hispanic or Latino, and the second largest group, African American. Next slide, please.
What is other in there that we can't categorize, Dr. Stevenson?
Pardon me now?
The 6% for other?
You know, either information not available, or, you know, could be you know, Pacific Islanders, Native Americans, etc.
Okay.
Do you want that broken out, DT, for next time?
No, unless the medical team things, there's a need for it. I just want to make sure the description, I understand the description on that.
Gotcha.
Okay. And then, this is just kind of interesting. This has been the breakdown of our patients by payer, and it's actually kind of a little bit different than what we see overall. We have a big chunk of commercial patients there actually, and JPS Connection representing only 16%. So it's a little different than we've seen with the overall population. That's interesting. Next slide, please.
I agree.
It's interesting. Are y'all digging in to find out what those factors mean?
In terms of why the different payers?
Why from what we've seen JPS Connection previously on payer, and why it's so low right now.
Well, no, that's just the COVID patients. I mean, overall, we see plenty of JPS Connection patients across the board. Just this subset of patients seems to not have as many JPS Connection patients for whatever reason.
Could that be, is there a possibility that they could not get a bed, so they go to a different hospital?
I don't think so. We've always been able to make more beds for them. So, it's interesting that, that such a large proportion of the patients are have commercial payers and they're willing to come. So, but
I like to think that the word got out that we have one of the most outstanding AHU ICUs in the DFW area, and people wanted to have the most evidence-based, outstanding care, and so a lot of patients with commercial insurance wanted to for their care for their COVID.
I'll agree with that, but I also am concerned that typically our JPS Connection patients or patients without insurance are the ones that don't feel that they have an option to come into the hospital, whether that is culturally, whether that is monetarily. We want to make sure that they're feeling welcomed, and also that there's enough community outreach for people to know that they should still utilize the hospital for any type of COVID related issues.
No doubt. I think you're right, Amanda, and I think a lot of patients, especially early on, were afraid to come to the hospital. They were afraid to come to the hospital. They were worried that they could even potentially get sicker. So that is a very good point.
Do we track patients with COVID that are staying at home that we monitor, like hospital at home type thing? Does it represent on that chart?
Yeah, so these are that's actually reflective of those who were admitted to the hospital. So that's the admitted group. I could see if we could get data on our patients who have been in the home monitoring program as well for next time, if you'd like. I think it's a pretty diverse payer group. So
yeah, I think Dr. Alawi can talk about our robust COVID clinic on follow-up. I see her there. Why don't you talk on that, Nadia?
Yeah, so I was going to say, we do have the data, our outpatient case management clinic. So we do have the ability to figure out the payer source. We do track those patients. We do keep reports on them. So we can definitely get that for you, DT, for the next quality meeting and update. I can also say that we are continuing to monitor these patients in our post-discharge COVID clinic. So all the patients that we do send out of the hospital are being followed up in a multidisciplinary post-COVID discharge clinic that has an internal medicine doctor, a pulmonologist, psychology, because we've noticed a lot of these patients suffer from anxiety, especially those that have been intubated. And so you've got the data on all of that. We can help Rob get all that so that he can present it at the next meeting.
Right. That would be great, because we are a health system, so a lot of stuff that our claim physician is monitoring and treating patients that are not reported here. That's why.
Absolutely. No, we can get that for you.
Good.
Okay.
Anything else on the COVID folks, Rob?
No, I just wanted to go through some of the things. Obviously, we're, with the, despite the governor's order yesterday, we're continuing to mask here at JPS. It's prudent. All the other hospitals are doing that. We've returned the surge carriers back to the usual uses. We are, as I mentioned, we are temporarily closing AHICU to upgrade the HVAC systems. We've reopened phase 1 elective surgery. We're looking at when we can reopen phase 2 elective surgery. We've got a few steps we need to do before we'll be ready to do that. And we just continue to remain vigilant. I don't know if Mr. Early would like to speak to where we are with the vaccine program.
Right, he is not available right
Oh, he's not here today. Okay.
Well, he's taking care of his dad.
Oh, okay. Fair enough. I guess the only thing I'll say about vaccines is we've so far at JPS vaccinated over 47,000 people. So far we continue to work through employees who come forward who still want to be vaccinated, as well as 1B patients who are within our network system. I believe we now have a green light to vaccinate educators as well. So I think those are the groups we're working on at the moment. But so far the vaccine program is continuing to go very well, and we are continuing to do our part as JPS to try to get as much vaccine into people's arms as possible.
Rob, Dr. Weber, the only thing I would add, this is Dr. Duncan, is that we continue to offer the Pfizer and the Moderna vaccine. We have requested the Johnson & Johnson vaccine.
Yeah.
But 47,000 people have been vaccinated.
Well, 47,000 vaccines have been given, I think is the better way to say it.
Okay.
Yeah, that's first and second doses, yes.
And
All right.
from what Rob just said, we did give the green light for educators and childcare staff to get vaccinated as well. And so that's gone out as notifications on our Facebook communications, as well as on our webpage, so that they are notified, and to all of our providers.
Okay.
And their notification, do they have a separate line that they're calling, or they just call the regular hospital JPS line? And also, do they have to be a JPS patient in order to receive the vaccination?
So I think currently we are trying to vaccinate our JPS patients first. There is a phone number that they can call. It's the Access Resource Center, but there's actually a separate phone tree that will take them directly to scheduling for the vaccine. And as we get vaccine allocation, we are making sure to open up the templates for them, so they can also, if they have MyChart access, be able to schedule themselves if they qualify.
Any other comments, Amanda? Any questions?
I have 2 questions on the COVID. With the governor lifting the ban, can we still legally require people to wear masks inside our hospital?
Yes, we can.
Okay.
And we have, and all hospitals in the area have, really across the state, we've pulled up all of their sites. They are going according to the CDC guidelines, and we do have signage posted that we continue to require that here at JPS.
Right. The second question is around the COVID identification of COVID patient. Are we keeping track of the POA based on a mission to see if they have COVID or they don't have COVID?
So right now we are testing patients in several categories. The first is, of course, patients who come in who have symptoms of COVID-19 disease. We test patients ahead of elective surgery. We test patients who are being admitted to behavioral health because it's a congregate environment and difficult to protect folks in that environment. So we want to make sure that those patients are safe and free from the potential for infection in that environment. But we do not test all inpatient admissions at this point in time. So we have used as a surrogate for, whether or not somebody may need to be investigated for developing COVID in the hospital if they test positive, if they've been in the hospital for more than 14 days and they develop symptoms and test positive. Those are the cases that we do deeper dives on to see what the likelihood of nosocomial transmission is.
My only cautious is, like everything else, if they come in with COVID, or we update it to make sure that, because we don't code these. Sometimes we have a policy to code later on with the right coding before we submit the bill out. And if COVID is not present on admission, then we may have to potentially keep track of that, just in case CMS down the road decided that if they don't have COVID at point of admission and they have COVID inside the hospital, that could be flipped over to hospital-acquired condition. So we may have to label or keep track of that as undoubtful account, just in case they change the law, change the ruling on it.
Yeah, I think that's a great point. We have always taken as a standard here at JPS molecular testing for making decisions about whether somebody actually has COVID or whether or not we are comfortable cohorting patients, in the same location. So that's always been really our gold standard here. And, right now you can get antigen testing very readily, but it has, pretty significant false negative rates and some concern about at least potentially slightly higher false positive rates compared to molecular testing. And so because of our reliance on molecular testing, the fact that those supplies are not limitless even now, that we have not, and most hospitals in the area have not been able to institute, a test all strategy even at this point in the pandemic.
Right. This is where the confusing part come in, and I just want to make sure that who's looking at it. Is that through our general counsel, through our EMR, through our risk enterprise, through our CFO, or quality? Because we can all look at a section of it, and then we could be all wrong because we're not looking at it from the whole, front to back.
Yeah. So the vast majority of patients who we ever identify as having COVID, the one piece of good news is the vast majority are identified on admission, either through the screening testing that we do, the little bit of it that we do, or because they come in with symptomatic disease. And so we have found very, very few patients who have turned up with COVID after that initial admission time. So I don't think it's a very large number. No, it's not a very large number, in fact. So
does that address your concerns, DT?
No, sir. Because I just want to know to make sure that which department will be, because we have coding, we have standard, we have documentation to make sure CDI and all that stuff. I just want to make sure that we line them correctly, because if down the road, if CMS is looking for a way to recoup or pay less in reimbursement, all that stuff, they may tighten up the rules. And if we don't have our documentation correctly, it's going to be a lot of time that we're going to have to spend down the road to go back and see what's going on.
No, I got you.
Appreciate the input. We'll make sure of it.
Yes, sir.
The one thing I will add, though, is that we do have to acknowledge that there's an incubation period for COVID. And so there is that possibility that the patient show up asymptomatic or even show up symptomatic and test negative, and then after a few days stay, then test positive. And so I don't know that CMS would be able to do that in the case of this type of infection, but I do believe that it's worth looking into. I agree with you.
Right, because it just, that's why I call undoubtful account, just to keep track of it, just in case. Because, the people from CMS may not be medical people that will be looking at it. And and they can come up with all kind of way to justify, and then we can, if we nail down everything correctly, we can always push back.
No doubt.
So we're going to lay that at Karen's feet, so to speak.
She's gonna hate me. Don't do that, Dr. Weber.
I was just going to say, Chuck, what did I do to you?
I did not volunteer you for that.
But actually,
Point
I
very well taken.
Yeah, no, I actually had just texted DT that I will look into it and get back. So it's on my to-do. Thank you.
Thank you.
All righty.
Thank you.
I mean, if we did, we probably one of the first in the country that will keep track of it on the side. And it's not something that there's no other hospital I know of is doing that. So, if anything, we'll be the first one to be careful on that stuff.
Well, good.
We love to be first, man. It's awesome. Thank you, DT, for all that. Really appreciate it. And that's all I have, Dr. Weber.
Okay, Rob. Thank you. Next, I have.
I guess I'll introduce my department though next.
You mean this guy that we're looking at?
Yeah. So, Dr. Weber, this is and committee. This is our second presentation of one of our key service lines. And this is, of course, near and dear to my heart, probably near and dear to your heart too, Dr. Weber. We're going to have the Department of Surgery. So just about a year ago, Dr. Richard Miller joined JPS after a distinguished career at Vanderbilt as head of general surgery and trauma. And we were incredibly fortunate to be able to recruit him to JPS and lead the Department of Surgery. And of course, now he's subsequently been elevated to also being Chief Medical Officer. Assisting him in the presentation will be Sujit Philippos. Dr. Philippos is our service line administrator for surgery, and he will be presenting our results in terms of our quality outcomes and initiatives in the Department of Surgery. So without further ado, I'll turn it over to Dr. Miller.
Well, thank you, Dr. Stevenson, and thank you, Dr. Weber, for allowing us to present a short overview of the Department of Surgery, both myself and Dr. Philippos, who is my partner in administrative duties and is the administrator for the Department of Surgery service line. Next slide, please. I just want to highlight a few of our champions. On the left is Dr. Steve Mapula. Dr. Mapula is our plastic surgeon who has been an integral part of a lot of our metrics that we're following and we'll show you. And he is also, along with his team, developed practice management guideline protocols and initiating minor burn service line where we are now able to take care of burn patients less than 20% body surface area. He has done a phenomenal job in educating nurses, nurse practitioners, and has a wonderful team that is interacting on burn care, wound management, and we're excited about starting that program here at JPS. Next to him is Dr. Victor Olivas. Dr. Olivas is the program director for our general surgery program and has been the liaison with our Baylor University Medical Center general surgery program and has done a wonderful job integrating that program and also working with Dr. Elliott in having medical students rotate on all of our service lines. Diane St. Pierre is our lead nurse practitioner in our optimization clinic, and we'll show you all the wonderful work that they are doing a little bit later in this presentation. I want to also say that she was the Excellence in Education Award winner for JPS this year in all her endeavors to educate people on the importance of optimizing patients before surgery. She and her team also have led all of the pre-op COVID testing and working with the clinics, following up the results and ensuring that patients are negative and prepared for surgery. So she's done a wonderful job. And finally, Dr. Van Johnson is our medical director of our surgical ICU. He has been an integral component in working with our medical ICU colleagues and collaborating in helping our colleagues in the COVID ICU managing these challenging patients. And so I give huge kudos to him and all the critical care surgeons. There are 6 of us that have been working with the MICU team in the COVID unit. And that collegiality and collaboration is priceless. And we have learned so much about this disease and working together as multiple minds in helping these patients. And that COVID ICU is a prototype of team play at its best. Next slide, please. Sujit, you're up.
Thank you. Good afternoon, Dr. Weber, the board, and senior administration. We are looking right now at the July to December 2020 key performance indicators for the Department of Surgery. So the first one is limb salvage. So our goal here is to decrease the number of non-traumatic lower limb amputations, primarily below knee amputations and above knee amputations for patients who suffer from diabetes, peripheral vascular disease, neuropathies. So how we did, so in 2019, our baseline was 16 patients per month, and we improved that by 25%. So it's right now at 12 patients per month, and we have hit goal for that. The way we did that was because of our multidisciplinary partnership with primary care, vascular surgery, podiatry, imaging, interventional radiology, and our clinics. So we had a bi-weekly meeting led by Dr. Cho, our vascular surgeon, and also we introduced some new treatment modality, bone marrow aspirate concentrate, which I would ask Dr. Miller to explain a little bit to us.
Yeah, sorry for not muting. I'm ruffling my papers, but so 2 really innovative means of reducing amputations has been new novel technology on bone marrow aspirate, where we aspirate bone marrow from the patient in a very scientific and defined way, and then inject it into a very complex wound. And additionally, we have Dr. Mapula undergoing a trial of RECELL, which is red blood cells that are grown in vivo and then sprayed onto the patient's wounds, and it actually takes the place of split thickness skin grafts, and the results so far have been phenomenal. So I am very encouraged that we will continue to improve outcomes in these patients that have severe peripheral vascular disease and diabetes and trying to salvage limbs.
Great.
So the next KPI measure is improving cardiac surgery standard of care in the ICU. And basically what this is creating a team from the operating room through transportation into the ICU with a huddle, so that we discuss the plan of care and ensure that patients are being extubated quickly, expediting their care and wean off pressors and getting out of the ICU as soon as possible. Our goal was to, at least for the coronary artery bypass patients, a very specific group population, we wanted to get them out of the ICU in less than 24 hours. And even though we had that ability to transfer them because of COVID and the limited numbers of step-down beds available, we were not able to achieve that goal. And a matter of fact, the vast majority of patients stay in the ICU for over that day. So hopefully in the future, we'll be looking forward to being able to utilize the standard of care, the huddle, and the team play in getting patients through their operation out of the ICU as quickly as possible. Another KPI measure is tactical program development of our emergency service verification. Dr. Carlos Rodriguez not only runs the EGS registry, but is also our main liaison for research in the Department of Surgery. And we have a very, very busy EGS service, busier than I had at Vanderbilt, and it's very important to ensure that we're capturing our data on emergency general surgery service and downloading that data into a larger data bank utilizing the American College of Surgeons. One of our biggest initiatives that I have a tremendous amount of passion for is trying to develop another American College of Surgeons initiative, which is the geriatric service verification. And what this is focusing in on elderly patients and their hospital course in all areas of surgery. Much of the meetings that we've had to try and become an ACS verified center of excellence for geriatrics has been on hold because, again, of our COVID surge. But the committee has multiple representatives from surgery, geriatrics, and our nurse geriatric coordinators. We've developed several criteria, and we've established a process for referral within our EPIC system and ensuring quick follow-up after patients get discharged. We've now established initial baseline metrics primarily focused on the folks over age 75 and greater who are patients, either trauma patients, general surgery patients, ortho, or podiatry. And there's 4 areas that we're focusing in on: preventing falls within the hospital, trying to minimize the use of restraints, and a lot of that has to do with reducing the incidence of delirium. Most importantly, reducing the length of stay. And as Dr. Stevenson alluded to, there is a huge population that we're going to see in the next 20 years that are very frail. And I've done a fair amount of research in frailty, both in general surgery and trauma. And this is going to be a big initiative as the population is growing older and people are developing a lot more comorbidities. So Dr. Stevenson and I have suggested that this be a large initiative with the Quality Council and all of the surgical subspecialties to really look at this group and determine, 1, whether they can be optimized for surgery, 2, what is the trajectory after trauma and emergency general surgery, and 3, how can we do a better job in preparing patients for surgery and then managing them afterwards. And finally, there is a patient population that does not do well after surgery or will not tolerate a very large operation, and we may need to consider other therapies other than surgery for those patients.
In relationship to surgical site infection for colon and the PSI, now Dr. Stevenson already shared the data, and we have achieved our goals for the latter half of the year. Over to you, Dr. Miller.
And finally, academics we're knocking it out the roof. Our goal was to get at least 12 papers or abstracts presented. And with the help of Dr. Rodriguez and our great research group, with the help of Dr. Elliott, we've bumped it up 3 times that much and have had 35 scholarly activities. Next slide, please.
Dr. Miller, before you leave that slide, may I ask a quick question? Can we assume that while you're doing the study, standard of care and all that stuff, you do include the anesthesiologist for anesthetic management for enhanced recovery for major surgery also as well?
Absolutely, and we are developing a task force because, as you know, we are transitioning from Envision to sound anesthesia. I am working with their chief, Lauren Jones, on all of these initiatives so that we have protocols, guidelines, and game plans for all of these areas right before they start at June 1. So yes, thank you, DT, for mentioning that.
Thank you.
Okay.
All right, so with provider communication, we have achieved all our outpatient provider communication goals. And for our inpatient doctor communication goal, we have only achieved 50%. Some of the steps we are taking to improve that is basically our patient experience mastery program, which is led by Dr. Miller and co-led by Dr. Miller and Laura Burnside, our monthly clinical experience series. So we are very focused on improving that. Dr. Miller, you want to talk a little bit about the patient experience mastery program?
So I really have the privilege of learning and working with Laura Burnside on this initiative. The mastery program is absolutely phenomenal, and we're trying to continue this in perpetuity with developing an office of patient experience. And along with our clinical experience series that we have every month, these are important factors to make physicians recognize how important the interaction they have with the patient in overall outcome. And the more we're actively involved with guidelines, protocols, communication, and having the patient and the family involved in their care, the better the outcomes. And so that's a huge initiative that we have, and I have really emphasized that to the entire department. The other thing that I think is really important, because as you know, trauma is a huge entity at JPS, and really our, excuse me, I have a dry throat, our customers are our pre-hospital providers. And we have initiated a feedback program where we interact with the pre-hospital providers, whether they come by ambulance or by air, tell them how good a job they did in transporting the patient, give them constructive criticism, and then follow up on what the injuries were for the patient and how they're doing. And we found this very valuable and a very important component of ensuring the best care of the patient from the time they get injured to the time they go to rehab. And amazingly, our numbers are also out the roof. In 2019, we had 65% feedback with our trauma EMS, and in this most recent year, it's 94.4%. So we're doing a really good job in communicating with the people that are bringing patients to us.
For provider engagement, we surpassed our goal. In 2019, we had 59% participation of our department, and in 2020, we had 76% participation in our department. And I also want to add another data point that we were the third highest engaged group in the claim. So. And then finally,
Suji, what was the last bit you said?
We were the third highest engaged group in the organization.
Good.
And then finally, the CDI queries. This is the clinical documentation improvement queries. This is a function of the medical record folks, where they have the CDI folks who comb through charts and send queries to providers in relationship to acuity. The response to these queries are very critical, and it has to be responded in a timely manner, because this affects the PSI rates. This affects the case mix index. So our performance in 2019 was 5.1 days in responding to CDI queries. In 2020, our performance was 1.7 days. So that's a tremendous improvement from our department.
Yeah, and I just want to add that, that requires a real team play. And I have to commend Sonia Baker in our office for really pushing all of the surgeons to ensure that they respond to queries very quickly. And now we have 100% response within 1.7 days. So that's phenomenal.
That's excellent.
Next slide, please.
You're muted, Dr. Miller.
Thanks. This has been my mission since I came here a year ago, is to really improve flow in the operating room. And the key to improving flow is to get started on time. And I've been looking at this along with Deb Saunders and others for this year. In 2019, we had 81% and we improved it to 83%, but really I want our goal to be close to 100% in 2001. So we took a deep dive in looking at what the things were that were hindrances to starting the first case. And interestingly enough, we found some things that we can really make a difference with. And one is never change the order of the first case. And I'm sure you're familiar with this, Dr. Weber. If that first case gets changed, then you're going to delay your case by at least an hour, because the whole op team that's in that room has to change all the equipment, all the instruments, et cetera. So we have made a policy that unless that first patient doesn't show up, which is not our, we work hard at getting them to show up, but if they don't, we are going to maintain that sequence and not change it. The other big thing was not getting consents completed, and so we have an initiative to get those consents done in the clinic when they're seen, and then reattest to them during the huddle. And again, no changes in procedures, no added procedures on the day of service. We're getting much better at getting surgeons on time and never late, and we're trying to get everybody to huddle at the appropriate time and get those H&Ps completed. And so at the bottom, you can see all of the issues related to not starting on time was quite a few hours, 253 odd hours of delay. And you can see that we personally are responsible for a large amount of that. And so if we can hone in on those certain reasons, I think we'll get well above 90, and I hope to reach above 95% in this next year. Next slide.
I also, Dr. Miller, I also wanted to add that we are working with Dr. Henderson to look at other technology ways to improve the on-time starts, such as RFIDs like radio frequency identifiers, badge readers, and Haiku, optimizing our usage on all these platforms. Thank you.
Good.
Dr. Miller, do you guys look into, once you start the procedures, I mean, there's a time estimate to complete, but there are times you can't do anything because you find more stuff in there that you need to take care of. But there's the other side of it is tools and supply and stuff like that, or sterilization that needs to take place that delay while you're doing the procedures. Do you guys see any of that is a problem? Because that left the patient open and an infection can come in through that delay type thing. So I was more concerned about infection rate and all that stuff than anything else.
And, that's a whole giant category in itself. On looking at infection rates. And as you know, the longer you do an operation, the higher the incidence of infection. So we do have standard times for doing certain procedures. And so if there are outliers, we try and find out why the procedure lasted longer than it did and hone down on that, whether it was equipment, whether somebody spent too long doing a robotic procedure, or there were other issues, because as important as on-time starts is the turnaround times. And environmental services, we are taking a deep dive as well at that. And Dr. Stevenson's quality and safety group is also looking at the infections within the OR.
So we will be able to see what's controllable and what's non-controllable type thing.
I believe we will be able to get that for you. Yes, sir.
Yes, sir. Thank you.
And finally, Dr. Weber, I just really want to highlight this really special team in the optimization clinic. On your left, they're all nurse practitioners, is Claudette Cook, and then Diane St. Pierre that I highlighted earlier, and Lindsay Holden. This group has been responsible for seeing over 1,600 patients in their optimization clinic over this last year of 2020. The top 5 reasons that they get patient gets referred to them is first and foremost to risk stratify whether they're able to tolerate an operation given their current comorbidities and current physical status. They focus on getting A1C levels down and treating diabetes and ensuring tight glucose control. They work on weight reduction programs, especially with complex hernias, mobility, and prehabilitation. As you know, smoking is a huge risk factor for post-op complications, both respiratory and wound management, and we are really working hard to ensure that we initiate a smoking cessation program at least 6 weeks before the operation to dissipate the nicotine from the body. And lastly, managing their blood pressure so that they don't get a stroke or an MI. The benefits of this team are now being followed, and the data is being followed, and we clearly have seen a tremendous improvement in outcomes based on this optimization team in decreased post-op complications, decreased same-day cancellations because patients are ready and are contacted and let know that they're ready for their surgery. Most importantly, decreasing their length of stay in the hospital. And as I said before, they are doing the testing. So along with this team and the Quality Council on geriatrics, emergency general surgery, and frailty, I think we will be leaders in this area in the near future. So, Dr. Phillips, go ahead. Sorry.
The top 5 referral reasons, I look at those. Are we using more like the NCQA HEDIS measure to standardize these, or how do we get them? Are you? I think you're on mute.
Can you ask me that question again? I didn't quite hear you.
The risk stratification, you know, diabetes, weight loss, and all that stuff, smoking cessation, and all that stuff. Are they following any standardization like NCQA HEDIS measure or anything like that, or how does that compile?
That's a great question. I know they have multiple standardizations, but I don't know if they're specifically following that one, DT. But what I'll do is I'll talk to Diane and see, and we can outline all of the stratification methods that they're using.
Thank you.
So that Dr. Philippos and I thank you very much for the opportunity to allow us to show what we're doing in the Department of Surgery. I am very proud of this group. I look forward to getting out of bed every day and coming to work because we are really a family away from our family. So thank you very much, Dr. Weber and board members.
Thank you. Thank you.
Good work, guys and ladies.
Thank
Anybody
you.
else have any comments, questions?
No, I have a lot of questions because this team really are very interesting. So you guys are the best of the best. That's why I have a lot of questions. Thank you.
Questions always make you better because you have to think about things. Anything else for Dr. Millard or Dr. Philipposi? Next I've got then is the Innovation Center with Disrip, Lauren Poe, and Dr. Alawi.
Yep. All right, if you'll allow me, let me give an introduction to this team as well. So Disrip, of course, has been a real jewel in the crown of JPS for a long time. Obviously, in front of the board on a regular basis are the financial benefits that we have been able to realize from the work that's been going on in this program. But today I really wanted to bring to this committee, to the Quality Committee, the individuals who have been leading this work to explain to you and to describe to you the incredible amount of work that goes on to achieve those results, and most importantly, the impact that what has been going on in the DSRIP program has had to our patients, and how they are, and how their health is doing, and how they are being able to live their lives better because of the work that's going on. And so without further ado, I'll turn it over to Lauren Poe, who's our Executive Director of Strategy, who's been, even prior to that role, has been sort of coordinating the DSRIP work, and Dr. Alawi, who has been our Vice Chief for Primary Care and is now serving as Interim President of Acclaim, who has, from the medical side, has been one of the real drivers behind this work. And so, so I will turn it over to them for their presentation.
Great. Thank you so much, Dr. Stevenson, and thank you, Mr. Chairman, and thank you to the board for really allowing us the opportunity to come before you guys today and showcase the really, like Dr. Stevenson said, the truly amazing work that the network's accomplished through the DSRIP program over the last several years. First and foremost, I do want to give a huge shout out, a kudos or a sincere thank you really to all the teams that have been doing the DSRIP work here at JPS. You know, although Dr. Alawi and I get to stand before you today and present this information, we really are serving simply as the voices of the larger teams that are, like I said, behind the scenes doing this work day in and day out. I will say, and Dr. Alawi can attest to this, DSRIP truly takes a village, and we have a village of teams, like I said, across this organization, from behavioral health to community health, our emergency department, several inpatient teams, palliative care, even our phenomenal team that we have in IT, that really have partnered with us to make all of this, like Dr. Stevenson said, the impact to our patient population and their health outcomes possible. Second to that, one of the things that we are so very proud of at JPS and the DSRIP program that we've built at JPS, and that we feel really is one of the biggest success and driving factors behind our DSRIP program at JPS, is the dyad infrastructure model that we developed on day one. And we'll talk a little bit more about that in a couple of minutes, but at every layer of this DSRIP program, we have developed a dyad model or infrastructure that has a partnership between both clinical and operational leaders. And so I've personally had the pleasure to have Dr. Alawi as my partner in crime over the last 3 years as we've really led this DSRIP work for the organization. I'll tell you, without her partnership, none of this would have been possible. Her leadership has been second to none, like Dr. Stevenson mentioned, from the clinical side of things. And her peers respect her so much. And so it's been a joy and a pleasure. So she's going to kind of be my partner today as we present this information to you. So with that, we'll go ahead and get started. You can go to that first slide. So just at a high level, just to kind of level set quickly on really what is DSRIP and kind of the background of the evolution of DSRIP. DSRIP has kind of had 2 iterations over the course of the last several years, and they've termed them DSRIP 1.0 and then DSRIP 2.0. DSRIP 1.0 lasted from 2012 to 2017. And that DSRIP 1.0 was very project focused. It was really project and milestone driven. So you received incentives for specific milestones that you achieved relative to certain projects that you committed to. And those projects were very focused on finite, small patient populations, targeted populations. So just so this group kind of understands, in DSRIP 1.0, JPS had over 27 different projects that we focused on. And some of those projects will seem very familiar to you. You just may not have known that they were a DSRIP project. Our call center was one of those. The expansion of our pain clinic and pain management program here at JPS was one. Our palliative care program that we now have, the expansion of ophthalmology, several of our homeless programs, those were DSRIP projects. Even our patient-centered medical home certifications were actually a DSRIP project in 1.0. So again, a lot of project-driven work. In 2017, Disrupt 1.0 ended, and CMS approved a second Disrupt program, what they termed Disrupt 2.0 in the state of Texas. And 2.0 was a totally different program. We like to say a totally different ball game. It was no longer project focused. It was no longer focused on finite patient populations that you had to or had the opportunity to select. It was now focused on your entire patient population within your health network, and it was all driven by outcomes and your performance on key outcomes measures and performance measures. And so here at JPS, we are still in the middle of Disrupt 2.0, and we currently have over 34 different outcome measures that we're responsible for. Those 34 different outcome measures span across several different areas of focus, from behavioral health, chronic disease management, maternal safety, palliative care, and several other areas. Like I mentioned before, just from a structural aspect, this is something we're very proud of. Each one of those areas of focus does have a dyad leadership model. So we have a physician or a clinician and an operational leader that partner together to drive that work across the organization. In addition to that, each one of those areas of focus also has a multidisciplinary work group team that works with those dyad leaders. And those work groups have representation from nursing, IT, pharmacy, imaging, if applicable, all the different areas that may touch a patient relative to that area of focus. You know, in 2.0, again, the ballgame changed quite a bit. And so we were not only focused on a small subset of patients, we were focused again on our entire population of patients. And it was quite challenging for all providers, because we had to develop a new way of thinking, and we had to develop a new model of care that we provided to our patients. So we had to start thinking about, how do we manage hypertension and elevated blood pressure in our patient population, but not only in primary care. What do we do about it when they come to a specialist and now they have their blood pressure is elevated at a specialist visit? How does that specialist contact their primary care provider? How does that patient get followed back up with? How do we start managing patients and first and foremost identifying them when they have depression outside of behavioral health? So how do we identify that in primary care? How do we identify that inpatient, ED? And what do we do about it? And then how do we proactively manage our patient population to make sure they never get into the hospital in the first place? And what are those preventative acts and processes that we need to put in place in order to make sure they never get there? As you're going to see in the next couple of slides, Dr. Alawi is going to walk you through that. The teams have done some amazing work around these 34 measures that I just mentioned over these 8 different areas of focus, with ultimately driving improved health outcomes and then healthcare delivery for our patient population. As expected, and Dr. Alawi will show you this, COVID did impact our performance from our year prior to COVID to last year during COVID, just like it impacted everything else. That was not unique to us. That was actually experienced by all of our peers in the state of Texas. However, I can say that the team really has put some focused efforts, even during COVID last year and now, to really get back on track and ultimately to make sure that those patients are getting the services and the care that they need. And the last thing that I'll say is, at the end of the day, and Dr. Alawi can definitely vouch for this and echo this probably, every single process that's been designed and implemented as part of Disrupt here at JPS was always done with the patients at the forefront of our mind, really with the ultimate goal of what is best for them and what is going to allow them to, again, achieve their best health outcome. For Dr. Alawi and I and the team, Disrupt is not about chasing a number on a scorecard, and it's definitely not about the dollars. It truly has always been about the patients and what's best for them. So with that, I'll turn it over to Dr. Alawi, and she's going to really be able to speak to the clinical work that the teams were able to do to accomplish the success that we've seen.
Thank you, Lauren.
Thank you, Lauren, and thank you, Mr. Chairman and the board, for having us here today. It's been my honor and privilege to work with Lauren for these 3 years on Disrupt, and to continue working with Lauren and her team on Disrupt. It has It has been a challenge over the last year. It was a challenge for all 3 years, but a challenge in different ways. As Lauren pointed out, standing in front of a bunch of orthopedic surgeons and explaining to them why managing blood pressure was important was a difficult conversation to have. They understood it from a surgical perspective, but it wasn't something that they needed to address on a daily basis until we forced them to, because at the end of the day, that was what was best for the patient. And they knew that, and they appreciated that. And I'll ask you to move on to the next slide, and we'll go from there. So this was our year-end results after 2019. And as you can see, we're almost in the green across the board. So I'll quickly go through our different metrics, but we had our diabetes chronic care metric, which required us to be able to complete foot exams, control hemoglobin A1C, control blood pressure in our diabetics, reduce emergency room visits for our diabetics, and that PQI 93 diabetic composite. That's somewhat of a complicated one to explain. It has multiple different facets. Lower limb amputation is one of them, along with any complication, whether it's long-term effect or short-term effect of diabetes that hospitalized a patient. And so that was that measure. Heart disease and hypertension was one of our bundles. And like Lauren said, I mean, the amount of work that went into these groups, the multidisciplinary teams that worked together on these groups, diabetes had diabetic educators on the group. Hypertension, we had cardiologists as well as primary care providers working together hand in hand to figure out the best ways to manage these patients. And we developed teams with case management and social work to try to control our heart failure patients and reduce our ED visits. Patient navigation and ED diversion had an amazing case management team working with both our emergency room team and our primary care team to try to get resolution and keep patients out of the ED unnecessarily. Cancer screening, also multidisciplinary. Maternal safety, looking at C-section rates, looking at antenatal steroid rates of use. I will say the C-section rate is an interesting one, because as you can see, our baseline is 22.1%. And that is lower than the national average for C-section rate. But this district measure requires, so district measures, there are different district measures. There are some district measures that were required to go against a national benchmark, and there's certain district measures that were required to improve upon self year after year. And this actually happens to be one of the ones that we have to improve upon self. And so the ability to drop the rate below what's already the national average was difficult for our team to do, and that was why they were unable to reach that measure at that time. Palliative care had an amazing team working. Those groups were working on a lot of assessments. They required a lot of IT builds to help them, and our EPIC team was integral in helping develop all of these builds for us. And behavioral health, as you can see, we had 2 different bundles for behavioral health, and Brenda Gomez, who is the operational lead on that team, and Dr. Smith from behavioral health and Dr. Lonergan from primary care did an amazing job of helping with our depression screening and management, our remission scores, helping our schizophrenic patients. They developed an ability for us to contact them in primary care if we had a patient who we thought might be a suicide risk, where that patient would get a phone call in under 24 hours from a behavioral health specialist to talk them through it. I'm not talking about a patient that truly has suicidal ideation, meaning they say they want to hurt themselves and they have a plan of action. But even just the inkling of a thought of maybe this world would be better without me. And that ability to have a behavioral health specialist on the phone with them in under 24 hours to really talk them through what they're going through and figure out what the best plan of action was an amazing thing for us to have built and ready to go. Next slide. So as you can see, COVID's impacts. So just to explain some of these, hemoglobin A1C and blood pressure, 2 things that were impacted strongly by COVID. And one of the reasons that they were impacted so strongly by COVID is because it's not truly just control. We actually have to have the measurement. And so when consolidation of clinics, with consolidation of our primary care clinics, the ability to actually get our patients physically in to check their A1Cs or to check their blood pressure was difficult. We were able to get home readings in case Disrupt was allowing us to use home readings on the patients that did have blood pressure cuffs at home. We set up drive-through hemoglobin A1C check stations to literally have patients drive through, get a finger stick hemoglobin A1C check, and drive back out to try to get as many patients in as possible. We put together care gap clinics to try to get patients in who perhaps had missed some of these because of COVID. And those providers were literally doing nothing but cervical exams and handing out fit tests if we had them, and getting those patients in for labs and performing foot exams and getting blood pressure measurements simply to try to get as many of them done as possible. But by the time we were able to do those things, and simply because of our surges and because of our staffing issues, because of the surges, because our providers and our staff all were needed on that inpatient side to help our sick patients, you can see the impact that that had to these numbers. Just to point out a few others, cervical cancer screening. Of course, you cannot do a pap smear via telehealth. That's a little bit difficult. And so that one is another one that we're now trying to catch up on now that we've reopened our clinics and we're starting to implement our face-to-face encounters. Colorectal cancer screening basically got shut down when elective surgeries got shut down. You can't do colonoscopies when elective surgeries are closed per edict of the governor. And so the reality is that we are now just trying to catch up on as many of these measures as we possibly can for this next scorecard. Any questions for me?
Yes. I'm sorry. On the data here, are we looking at Disrupt data pertaining to Medicaid, or are we looking at it with JPS connection also as well?
Yeah, so that's a great question, DT. So Disrupt actually tracks data for what they term the MLIU population. So that is Medicaid, low income, and uninsured. So all of our metrics that we report to the state have to be reported for that population. So that does include our JPS connection population, Medicare, Medicaid, and then our truly self-pay patients. We also track the same measures for all payer internally, but what actually gets reported to the state is MLIU. And the other thing that Dr. Alawi, you can go to the next slide.
Can we stay on this one a little bit, just a little bit long? Just want to make sure we got the, as far as the data goes, how do you get the data and how do you set, because you have the baseline here, but I don't see the numerator and the denominator that fit these criteria.
Yes, no, great question. So I do want to give a huge shout out and thank you to Mansoor and Sajid and their entire IT team. The data work that goes behind this is a lot. And so they actually spent well over 6 to 9 months at the very beginning of Disrupt 2.0 developing the 34 reports that you see that make up the scorecard before you. So what we do is we utilize the spec document from the state of Texas, which is approved by CMS. We utilize their technicality spec sheet and develop the reports based off of those tech specs. Every single provider in the state of Texas has the same spec document, so we all have to follow the same rules. And then these reports get generated out of Epic every month by the IT team, validated, an intense data validation is done. And then what you're seeing here is simply, to your point, DT, just the percentage and or rate that we have to report. But underneath each one of those, behind the scenes, is a numerator and a denominator. And we actually use those reports on an operational basis to start to identify the patients that really make up those numerators, so that we can say which patients are not meeting XYZ, and we can drill down to the patient level and begin reaching out to them. So we utilize the detailed data that's behind the scorecard, but what you see today is the scorecard. And I think your second question too is how we set threshold, baseline, and everything. The state of Texas actually outlined what our threshold or, targets, et cetera, needed to be based off of their qualifications. So we did not set that. That was set by the state of Texas and CMS.
Mm-hmm. But how do you get the data and who set internal standard what data you receive? Because sometimes you have different data, you have to bind them. Like for instance, if you're going to have Medicare or you part of the Medicare system type thing, sure. Then you have to receive it. You have to receive a CCLF file and all that stuff. Do you guys have access to that?
So for DSRIP, this scorecard, it does not look at payer data. This scorecard is generated for DSRIP program. The state of Texas only allowed you to choose one way to report or the other. So you could either choose payer reporting claims level data, or you could choose EMR data. Most all providers in the state chose EMR data, and that is what we chose to go with for the DSRIP program. So the data, you can't merge data for DSRIP, you have to pick one or the other. So our data is all generated by our EMR within Epic. Okay. So
just to clarify one other thing real quick, Lauren, our data was also, we worked very hard with our IT team to build ways within Epic for the data to be automatically generated. So none of this required a manual chart review to collect the data. The data was able to be collected completely electronically, and it was validated through multiple charts to make sure that we were collecting accurate data.
Right, but if you have the EMR data coming from the health system, you may not have enough EMR data. You don't have a 360 view of that patient. What if they go see an ancillary, a different doctor outside the network? You won't have them. So how do you reconcile missing data?
So in the case,
people use paid data from the insurance company rather than from Medicare, Medicaid, rather than from just don't have the complete medical record.
To use our connection patient data. We wouldn't be able to use, because our connection patients and our self-pay patients don't have claims data. So we wouldn't be able to use the data for any of those if we used claims data. And so the way that we reconcile claims data with our, or claims information is if we have internal records from outside sources, or if our patient states, I got a colonoscopy 2 years ago, or I had my mammogram just last month, but they didn't do it within the system, or they had lab work done outside of the system. If it's in here everywhere, we are able to reconcile it automatically. If they bring it with them, or we obtain the records from the outside source, we're actually able to include it into our medical record to be accounted for in the reporting. And so we have done a very good job of accumulating all of that data from our patients and getting it into our reporting to the best of our ability. But because you're right, this data does tend to be more accurate for that full 360 view. The issue is the connections in the self-pay patients that don't have claims. And since DSRIP, the program from the state, will not allow us to use both types of data, the EMR gives us the more accurate data for all the different groups.
But you won't have post-acute care data, though.
In the sense of
just on the EMR system, the Epic EMR system.
But
because if you're looking for the marker on the medical record, or from procedure that they come in for, and if they're outside of your system, you won't have a 360 view. You may have it from the JPS connection, as long as they don't go to post-acute care, because we don't have a post-acute care. But if they are Medicaid or Medicare patient, the chances are you don't have the 360 view. So that's why I was worried about how do you set up the numerator and the denominator to fit those criteria for you to look at and set the baseline and benchmarking.
So I'm trying to clarify what you mean by post-acute care, because like once they go home from the hospital, or?
Right.
So because when I think of post-acute care, I often think of a like nursing facility or something of that nature. So post-acute care in terms of when they're discharged from the hospital.
Home health, DME, all sort of things, right?
So most of the EPIC data, the denominators are set by our patients that are in the system, right? So they're in our system already. Many of them already have primary care providers within our system as well. So it's not as much hospital data. So the A1Cs that we're looking at, I mean, if they go to the hospital and they get an A1C, we're looking at that. But we're more looking at the data outside of the hospital than inside of the hospital. If they go to THR or Baylor or any of the other systems that are in Care Everywhere, that data is actually automatically inputted into our EMR. So we actually have that data automatically as well.
Do we have those? Because at one time we were talking about the EMR and we couldn't sign on to the EPIC Everywhere, whatever they call it, because of the liability reason. I mean, is if one breached, everybody else pay, regardless if we breached the security or their staff security. And I don't think the team ever come back to the board to ask for permission, because that's opened up a different liability. And we never did have any update on that since 5-6 years ago. So is it on or is it off for that particular one?
So Care Everywhere is on. I cannot speak to the liability of it or that conversation. I don't know if Daphne's on this call or not and can discuss that, but I can definitely have someone circle back and bring it back, DT. But I do know that Care Everywhere is on.
Right. And
okay. My apologies. For whatever reason, my computer completely froze in my office, so I apologize for that. But I did want to, kind of circle back, and we can go to the next slide, because one of the key things that, as we talked about at the beginning of the presentation, the true outcomes for the patient population. If you'll go back one slide, I'm sorry. Mm-hmm. I'm not going to go through all of these wins. These are just several of the many wins that we've seen improve health outcomes in our patient population. But I do want to call attention to that bullet point number 2. This really speaks volumes truly to what the district program is all about. So from 2017 to 2019, our stage 4 breast cancer rates decreased from 14% to 7.5% here at JPS in our patient population. At the same time, our stage 0 to 2 increased from 67% to 78.5%. When you marry that with that bullet point number 1, again, it's all about prevention. It's all about population health and truly managing the population to make sure they're getting the preventative care when they need it, so that ultimately you see those results in that bullet point number 2. And so I just wanted to call attention to the fact that, at the end of the day, like I mentioned at the beginning, all of this work has been centered around our patients and what's best for them, so that we ultimately can make improvements in their health like you see in that bullet point number 2. With that, Dr. Alawi, I know that was the end of the presentation, but we are free to answer any additional questions that you guys might have.
Well, my concern has always been the same, Lauren, and I still don't have the right firm definition of how you guys get the data. The work's been done is amazing. I mean, there's no doubt about it. But my concern is if we can report back to CMS or the Medicaid, the government, I'm very, very focused on the source of data and the integrity of the data, and I never get a very clear explanation of how the data has been binded and to be used. So has always been my concern, and I don't think it's ever been addressed. And we can sidestep it all we want, but there are points where we can have to face the music.
Sure, and DT, I would be more than happy to meet with you offline to at least explain from the district perspective our data pieces, and kind of walk you through in detail of what we have, knowing that that's just one component in one program, right, of all the different CMS programs. But I'd be more than happy to meet with you.
Okay. Well, you may want to include Dorothy also as well. I know she's very interested in that also as well. I think she's on the phone too.
I'm here, and I wanted to ask Lauren, when you said they could make two, you could either do it off of Epic or they could do it off of Claim. Did the majority of the folks do it off of Epic, or did some of them do it off the Claim data?
The majority of the providers in the state chose to do the EMR, not necessarily Epic, so I apologize for saying that, but EMR. So whatever EMR they use, we just happen to use Epic rather than claims. Specifically, again, because like Dr. Alawi mentioned, it's hard to get claims data for those other patient populations that are not Medicare, Medicaid, or a managed, commercial contract. And so the majority of really all providers, if I remember correctly, chose the EMR data for again, this is for this district specific program though.
Okay, so you're saying that none of those, I guess I just have a hard time seeing that we treat patients, they JPS connection, they come in our system, you do generate a bill and it just disappears and we never look at it. So
no, we do. The hard part is a lot of the items that they're asking for, Dorothy, are not actually in a claims level data report. So a lot of the things, you're only able to pull in a claims level report those things you bill for, and a lot of the things that you have a modifier, et cetera for, and a lot of the things that we're capturing here in these metrics are not included in claims level reporting.
Okay. All right.
No, this is DT. This is the reason why, we like and we hate EMR data. I'm not going to name the name of the health system, the big health system in Houston. They go in and scoop data, medical record from their IPA and their ACO without authorization. And that is the key problem, because once you receive, you can quantify and look at it to verify, to make sure, because there is a discrepancy between paid claim and what's being done in the medical record. Because the insurance, those are paid claim, but you're better off at this moment in time when things haven't been decided yet, to get the information that the insurance can give you versus rely on scooping electronic record that may not cast some type of authorization from their own medical doctor type thing for their record. And assuming that they have everything in Epic, EMR everywhere type thing. But the possession of those data can get us in trouble also as well if we are not authorized to get them.
I'm not sure what I understand what you're asking for, DT. What?
First of all, we don't have enough the 360 view of that patient when you're looking at from that perspective, because you can only control the medical record that you have in-house.
Right.
But when you get input from other source that providing the service to their physician, some health systems do not have the right credential to go in and look at the medical record of their independent physician, and they scoop it anyway behind the scene because they have the password and the master password and all that stuff to go in. And that's another concern that I have, is the possession of that data that
sure. And DT, I can speak to, so from the standpoint of what we're pulling, we're not pulling anything of that nature. So for what we're pulling for these reports, it's truly A, what's happened in our system, and then B, if it is something, I think Dr. Alawi, that's kind of when my camera cut off, but a mammogram or other things, we actually have to have the patient sign a consent form in order for us to reach out and get those mammogram reports or things that were done by another physician at another facility. We don't just scoop data without the patient knowing to just pull it into these reports or to the record. If they're being pulled in, it's either what was done at JPS and or it was approved by the patient through a consent form, a release form for us to be able to get that information. And part of that does go through that Care Everywhere process, but we do have the patient sign consent forms for release.
But if that is the case, then statistically, can you tell if we have all the data necessary for that, so that we can come up with the numerator and denominator to say that statistically these numbers are correct from that standpoint, or it's just based on what we receive and these are the things that we're doing? Because it could be a concern if it's not statistically correct.
No, that's a good point, and I think that in what we've experienced, I think that most data, there's always going to be a little bit of a gap there or the unknown gap, but from the standpoint of what we use for DSRIP, I think we're confident that it does capture at least the needed components for the DSRIP program.
I guess I'm the only outlier that have questioning about, it trash out. So I don't want, I'm not going to discredit the medical team. The medical team can only execute based on what the data show. But are we doing the right thing, or are we creating more work for them that doesn't have the right yield? That was my only concern when we do this stuff.
And we appreciate that, DT. So what we can do is we can try to get that information, as much of that information for you as possible, and circle back and get that for you either at the next meeting or offline, but we will work on that for you.
Okay.
I have one question on the COVID impact score sheet, and it's under the maternal safety, the OB hemorrhage risk assessment. I don't understand. It's got a baseline of 13.8, 23, and then 69 as your result. It's they're having more hemorrhage. I don't understand that score.
No, it's actually the use of the assessment. So it's actually a pre-assessment to determine what a patient's predicted OB hemorrhage amount will be. So that's actually the completion rate of the assessment being done. We improve.
Okay. All right. Thank you. Thank you.
You're very welcome.
Yeah, I think I know what you're asking for, DT, but I'm not completely 100% I understand.
It's no, I just want to make sure the integrity of the data, Dr. Weber.
Right, I understand that.
And then also, if we're going to take medical record, we need to be also prepared to build in some kind of checking to make sure, because sometimes you can see people may go outside, especially imaging and lab. They're going to pick places that are the lowest cost. And then when things pop up that they actually have certain things that that may need to require surgery and all that stuff. And then, some system, they may go outside and they're forcing them to do some more imaging because it's not read and done inside the facility for nothing but revenue cycle to control the revenue. And for those instances, we need to look at to see how do we reconcile, how do we look at those things and make a determination to see how things are reported and all that stuff also as well. It's a lot of stuff. I'm just more worried about the integrity of the data, because any of these stuff is to drive the revenue and the bonuses that CMS is giving to us. And that, I just want to make sure we don't wander into area where we can get in trouble down the road for reporting something that we know may have data problem.
So DT, Dr. Henderson just reached out to me, our Chief Medical Informatics Officer, and he said he'd be more than happy to get with you offline and go over all the details about how the data is collected so that you have a better idea of that data integrity.
Yes, ma'am. All right, thank you.
Absolutely.
Get me on that as well, Lauren, if you would.
Yes, we can definitely do that. Anyone else want to be part of that?
It would just be a good deal for him to just to educate us on that, you know, as a board, so we would know this is what we're dealing with and this is how it looked at. That should be an education for the quality for the board. So that's what I would recommend, that we kind of add that, because I'd like to know. Amanda's, I see her head going up and down. Yeah, she want to know. So maybe some education for the board on that data integrity. Okay.
Absolutely. So why don't we have him come present next month, Rob, if that's okay with you? We'll have him present next month about the data and the data integrity. Dr. Stevenson?
Sounds good. I'll make sure he gets it.
Dr. Stevenson, we only have a 12-hour limit, so don't go over that. No, I'm just kidding.
Well, I will probably adjust the agenda next time a little bit to allow for robust discussion on this issue. You know, so we will look at that, but I think that, you know, we'll make sure that you have plenty of time to hear from Dr. Henderson and to ask any questions you need to ask. So we'll craft that agenda very intentionally to make sure that you have time.
If it's okay with our chair, I don't mind having an offline meeting to get some of this stuff so that we don't bog down the meeting. I'll be glad to do that also as well.
Is there any issue if practically all of you want to be there? I think that's the only question. From Daphne, can you answer that?
If it's just an educational session and we're not reporting out information, we can arrange that.
Okay, sounds good. Well, let's try to do it offline then. I'm certainly content with that. As we have lots. I already sort of know what we're going to talk about next month, and there's a lot to talk about. So.
Well, on behalf of the district teams and all the work groups across the network, again, thank you guys so much for allowing us the opportunity to come present about the work and ultimately, like I said, the impact that it's had on our patient population. So thank you guys.
Thank you.
And I want to say thank you too. That was a good report. Okay.
Lauren, I have a question. On your first slide that says district wins.
Yes, sir.
You got that? The 1, 2, 3, fourth bullet point is you've increased the 6-month depression readmission rate from 0.27 to 22.59.
Yes. So remember, this is not readmissions, right? This is remission. So this is,
okay.
Yes, not readmission, but remission.
My error.
It's okay. It's a common mistake.
Yep. My fault. I should have been paying more attention.
That's okay, Chuck. They explained it to me last time. Too, okay?
The important thing to remember is it just means less people are depressed, which is always a good thing.
Gotcha.
That question's supposed to be coming from me as a not English-speaking guy, Dr. Weber.
Okay. And with that, there's nothing for closed session that I'm aware of. So anybody like to make the motion that we adjourn?
I move to adjourn the meeting.
Dorothy, I second.
All right. See ya. Thank you.
Okay.
Thank you.
All right.
Bye-bye.
Bye-bye.
Bye, Sharon.
Adios all.
See ya.
Okay.
Hey, Brian.